Professor Franklin, you don't need to wear a mask while you're giving evidence. It might help, in fact, if you don't.
No, I'm sure it will. There we are.
May you be sworn.
Please state your full name.
Ian Maxwell Franklin.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but
and
the
nothing
truth.
but the truth.
Professor Franklin, I'm going to ask you first just for an overview of your career. You undertook, I think, various house officer and senior house officer roles in Leeds between 1974 and 1976.
Yep, I did.
And then between, I think, 1977 and 1980, you were a research training fellow for the Medical Research Council.
Yes.
Your work then, I think, was predominantly related to sickle cell anemia.
Yeah, the research was, yes.
Did you undertake any clinical work during that period?
I did nothing for the first year, and then I used to attend a sickle cell anemia clinic at the London School of Hygiene and at University College about a couple of times a month, and that carried on for the last 2 years. And then the final year, I used to go and help a general haematology clinic at the now defunct Royal Northern Hospital.
And then from 1980 to 1982, you were a senior registrar in haematology at University College Hospital.
Yeah, based there, yes.
And that was your specialist haematology training to achieve membership of the Royal College of
Yes.
Pathologists. Your statement and your CV tells us that between October 1980 and February 1981, you worked for approximately 3 months at Great Ormond Street Hospital under Professor Hardesty.
That's right, yeah.
And so you would, in the course of that period, have seen children with bleeding disorders. You say you didn't have a decision-making role in terms of what treatment to provide to them.
No, I didn't. It was observational, I would say.
Can you recall anything about what the treatment policies were at Great Ormond Street at that
I can't really. I remember they had Lister Factor 8. I think that was the first time I'd heard of Lister Factor 8. I don't remember whether they had commercial product, and I don't remember seeing cryoprecipitate used either.
Then from March to September of 1981, you were training in blood transfusion medicine under Dr. Barbara at the North London Regional Transfusion Centre in Edgware.
Well, I worked with, I didn't work with him. He taught me about transfusion virology, but also Dr. Marcella, now Professor Dame Marcella Contreras, was the haematologist who was actually leading my training.
You've said in your statement that the focus in terms of what you recall learning there was on hepatitis B. It would seem likely that there must have been some discussion of non-A, non-B hepatitis and its risks at that time.
I think there was some. I mean, I have to say that outside the world of haemophilia, I would say even in general haematology, there was probably a lack of appreciation of the level to which blood transfusion, red cells and so on could transmit non-A, non-B hepatitis. I mean, I think there was, I'd heard of it. I think there was a feeling that it was something that largely happened in the United States because of paid donors, and that the volunteer donor base in the UK was much safer. So from that point of view, there wasn't a lot of exposure to knowledge of it.
And then you moved to St Albans City Hospital, where you spent, I think, around 3 months doing general haematology work.
Yes.
And then January to August 1982, you were at UCH. You've said in your statement you were mainly concerned with the development of a bone marrow transplant programme.
Well, my boss, Professor Tony Goldstone, was setting up the programme there. He'd been doing that for a year or so. I was involved to a very small degree while I was still a research fellow, but then, I was quite involved with the early transplant patients that were starting off what is now a very big unit.
And you've said there was no involvement with the care of those with bleeding disorders, save for the odd patient.
Well, yes. I mean, I remember seeing the occasional person with haemophilia on the wards, but it was a haemophilia centre, but couldn't have had many patients, I think.
Did you have any involvement in decisions as to how to treat those occasional patients?
I don't remember having any such role, no.
And do you have any recollection of what treatment was routinely provided?
No, I'm afraid not, no.
And then on completion of that specialist training, you gained membership of the Royal College of Pathologists.
Yeah.
And then in September 1982, you took up your post as a consultant at the Queen Elizabeth Hospital in Birmingham.
Yeah.
And you were, I think, around 33 years old at the time.
Just about, yeah.
Now, your statement suggests that your appointment was principally to develop a bone marrow programme and because of your sickle cell experience. Is that correct?
Yes, I mean, they had quite a large sickle cell population, which I think made me attractive. But they particularly wanted to start doing bone marrow. We call them now stem cell transplants, bone marrow transplants, yeah.
And so in terms of haemophilia care, Professor Stewart was still the director of the Haemophilia Centre at that point. And for that first 12 months, your statement describes you only dealing with the care of patients with bleeding disorders when you were on call.
Yeah, so if we had haemophilia patients in the ward, you would see them on the ward round during the day, and then if there were any issues, deal with them at weekends or at night. And as you're fully aware, the haemophilia care was a 24-hour service. Men could come up for treatment to be seen on the ward. The treatment room was next to the ward pretty much any time of the day or night, so I'd get involved to some extent in those episodes.
Okay, I'll ask you a little more about that in a few minutes.
Yeah.
But you then took over as the director of the Haemophilia Centre after approximately a year, so in September 83 or thereabouts.
Yeah.
Did Professor Stewart continue as a consultant, or did he retire completely?
No, he obviously he was a professor. He had a research interest, but then he continued to provide out of hours cover on a 1 in 3 rota and at weekends. But he was largely retained responsibility for the laboratory and the hospital laboratory and his research.
So is it fair to say that at the point at which you became a director of the Haemophilia Centre at the Queen Elizabeth Hospital, your direct experience relating to the treatment of patients with bleeding disorders had been largely limited to those 3 months at Great Ormond Street and then the first 12 months at QEH working with Professor Stewart?
I would say I was quite inexperienced, really.
You remained consultant haematologist and director of the Haemophilia Centre at the Queen Elizabeth Hospital until the end of July of 1992.
Yeah.
And then moved to Glasgow
Yeah.
to take up a role as a consultant focusing on bone marrow transplantation. Yeah. And you then worked for a number of years thereafter in the blood transfusion service, initially locally and then as SNBTS's National Medical and Scientific Director.
Yeah, I started as National Medical and Scientific Director in early '97.
And I think you remained a professor of transfusion medicine throughout that period.
Yeah, I had that, and I continued to work on the transplant unit as well.
And then 2011 to 2014, you had a similar role at the Irish Blood Transfusion
Yeah,
Service.
that was just solely the medical and scientific director with no other hospital role.
Now, as I think you know, the questions I ask you today are going to be focused upon your work at Birmingham.
Yeah.
I'm not going to be asking you about your work in Scotland, although that may be something that the inquiry will need to ask you about at a later stage of its hearings. In terms of working parties or organisations you belonged to, you were, once you became director of the Queen Elizabeth Hospital Centre, a member of UKHCDO.
Yes, I think that sort of went with the territory.
I think we've only got a record of you attending 2 meetings, one in 1983 and one in 1984. Does that sound about right?
Yeah, I don't remember, well, it was a long time ago. I didn't actually remember many of the West Midlands working parties either, other than the early ones, but I don't think I did go to them after that.
And as you just alluded to, you were a member of the Working Party on the Treatment of Haemophiliacs for the West Midlands Regional Health Authority, and we'll look at some of the minutes of that in the course of your evidence. You gave evidence to the Archer inquiry.
I did.
You, I think, had some involvement in some litigation against the West Midlands Health Authority. You had to provide some schedules, I think you said, in relation to patients, without obviously discussing any individual case. Can you recall the nature of your involvement?
There were 4 legal cases, I remember. 2 of them related to areas of relevance to this inquiry, but none of those, I don't think any of the cases got to court. I think those 2 were both, they didn't proceed. The other 2 related to issues with care of haemophiliac, people with haemophilia, and I believe, but I'm not sure, that they were settled out of court.
Can I ask you just to give us an overview of what the facilities were at the Haemophilia Centre at QEH when you took up your post as director in 1983?
Well, first of all, I had a co-director, Dr. Frank Hill, who came to the hospital once a week to do the clinic, as I remember, in the morning, and then we would meet through the afternoon to discuss problems with particular patients and strategy, I suppose. We had a single room which was like a large office, which was a treatment room with a treatment couch where patients could have their treatment administered, whether that was factor VIII, those not on home treatment. I remember us giving fever in there as well. It was just one room. We had patient records in there, definitely patient records of home treatment, so that would be sheets that the patients themselves had filled in. I don't remember whether we had all of the patient records in there. I don't believe we could have done. I think they must have been stored somewhere else in medical records, but we certainly had quite a lot of filing cabinets with records. We stored working stock of factor VIII concentrate. It was quite a busy room. I think cryo was stored down in the blood bank, not in that room. We only had facilities in there to treat one patient at a time for reasons of confidentiality, so that was a bit limiting. We had one nurse of sister grade who was full-time for haemophilia care, and she would see patients who attended, whether for home therapy advice or supplies or people not on home therapy with a bleed. She may be able to manage a lot of those, otherwise she would then refer to doctors, which would depend on who was around really on the main team. Medical support in addition to myself and Dr. Hill were provided by a senior registrar, one registrar and a couple of senior house officers, about 4 junior level doctors. We had quite a good coagulation laboratory, which was down in the hospital laboratory. But that was about it, really. There was no. I suppose we had a room 2 rooms in an outpatient clinic, but that was part of the general outpatient facilities. So really, in terms of special facilities, there was really just this one room and one person, one nurse.
And in terms of doctors, we'll come back to your role and Professor Hill's. You've mentioned in your statement already, and your evidence already, Professor Stewart, there was a Dr. Brian Boughton. Boughton. Did he have any involvement?
He was a senior lecturer. He really only was doing the same as I was doing in the first year, which was 1 in 3 nights and 1 in 3 weekends covering.
And were there registrars, senior registrars, who participated in the work of the clinic over the years that followed?
Oh, yeah, depending on, they a bit like me in my training, would rotate through the department. There were other hospitals in the area, Coventry, the Birmingham Children's Hospital, General Hospital. So they all had junior doctors who would then move round to ensure that their training was covered all the specialties.
So Professor Hill would come and do clinics jointly with you at the Queen Elizabeth. Did you have any involvement in clinics at the Children's Hospital?
No, never.
Can you recall when you started at Queen Elizabeth Hospital, so first appointed as a consultant but before you took over as director a year later, was there any particular guidance or training that you recall being given by Professor Stewart?
You know, I don't remember, to be honest.
How did the relationship with Professor Hill and the fact that you were co-directors, how did that work in practice?
Well, I think it worked pretty well. I mean, I had a bit more time to spend than him, but he was a trained and experienced haemophilia, well, I would say haemophilia expert. He'd trained at Great Ormond Street, he trained in Oxford, and the systems, although barely sufficient for the management of the bleeds in the men with haemophilia, I thought it was actually quite well organised in terms of managing the treatment.
You said in your statement that you were to some extent guided by Professor Hill because he was more experienced. You also told the Archer Inquiry that because you were, I'm not directly quoting from you, but you were relatively inexperienced.
Yeah,
you needed guidance from more haemophilia experts and tried to follow a consensus opinion. Is that correct?
Yeah.
Just have a look at, in terms of a rough idea of numbers of patients, Professor Franklin. Could we have UBFT 40252, please, Henry? This is a report prepared jointly by you and Professor Hill in April 1986. It was a request for further resources, and we'll come on to that at a later stage of your evidence about funding problems for the care of those with HIV. But if we just look at the second paragraph on this page, please, Henry, we can see it said, the haemophiliac population within the West Midlands represents 11% of all the haemophiliacs in the UK. The majority, about 75%, are registered with Queen Elizabeth Hospital or Birmingham Children's Hospital. At Queen Elizabeth, there are 423 patients registered as having a bleeding disorder. Of these, approximately 90 attend regularly for therapy or use factor VIII concentrate at home. So that's an accurate snapshot, is it, of the numbers?
I think so, yeah.
And I don't think we need to go to it, but in a report the following year, you described Queen Elizabeth Hospital as effectively the 5th largest haemophilia centre in England and the largest not to receive any bespoke funding as a reference centre.
Yeah, I don't particularly remember that. In fact, I only really realised how large we were until I was preparing for this inquiry. But yeah, it was clearly quite a big centre.
I think it's right that during the time you were director, the QEH didn't have the status of a reference centre.
No, I think they changed. They seemed to be quite obsessed with the rules around what a reference centre was. The UK Haemophilia Centre Doctors Organisation. I think the Children's Hospital became a comprehensive care centre.
Yes, in 1989.
Yeah, so I think they changed the nomenclature, but no, I think the adult centre remained the same status.
Can we look at the annual return for 1983, again, just to get an idea of what treatments were being used at that stage? Henry, it's HCDO 4026_002. So this is for the treatment of patients with haemophilia B. And we can see it's 1983 return, director, yourself and Dr. Hill, 9 patients with haemophilia B. And the sole treatment there, NHS factor 9 concentrate, and we can see both hospital and home
I
treatment.
think I've got a
I think we're
different
looking
one.
at,
Oh, I'm so sorry.
we're looking at the wrong page. We're looking at
I
page
am
one.
looking at the
We
wrong
should be
paper
looking at page
document.
two.
Yes, I'm so sorry. Yes, sorry. This is the 1983 return for haemophilia A patients, carriers, and von Willebrand's disease. So we can see 83 patients treated during the year with haemophilia A, 3 carriers of haemophilia A treated during the year, and 13 with von Willebrand's disease treated during the year. And then we can see the products being used: cryoprecipitate, 97,090 units, and that's just for hospital treatment, so no cryoprecipitate for home therapy by that time. Does that accord with your recollection?
Yes, I don't remember any patients still, if they ever were, still being on cryoprecipitate at home.
And then NHS factor concentrate we can see being used both in hospital and for home treatment.
Yep.
338,000 odd in hospital, 569,000 odd for home treatment. But then the predominant product is the ARMA factor 8, so the commercial product, a smaller amount used in hospital, but 1.2 million used for home treatment.
Yeah.
And we'll look at some of the contracting arrangements in a little while. So that's haemophilia A patients. Von Willebrand's we can see treated solely with cryoprecipitate. And then if we go to the documents I had been looking at, sorry Henry, HCDO 402006_004. We can see there 9 patients with haemophilia B, no carriers, and the sole product used both in hospital and for home treatment is the NHS factor 9 concentrate.
Yeah, I think we always, as far as I remember, we always had enough NHS factor 9.
You said in your statement that the home treatment programme was established before you took up your post.
Yeah.
And you didn't remember actually starting anyone on home treatment yourself, is that correct?
No, I don't remember doing that, no.
Was there any programme of prophylactic treatment at the time?
No, I don't. Well, I don't remember that, and certainly I don't think there was in the adults. Prophylaxis was talked about and considered to be beyond our ability to afford it, I think, probably.
Now, there was one of the treatment policies in operation when you joined was a policy of trying to keep patients on the same product. Mm-hmm. Can you explain how that worked?
Yeah, well, that's taught to me, and I think it does make sense. The idea was that once you were exposed to one batch of product, it would be best if you continued to use that and not be given either different batches of the same product or lots of different product. And the idea there, I think, is to try to restrict the number of donors to which a particular person is exposed. You're still going to be exposed to a lot of donors, but if you had, let's say you had 3 treatments from the same batch of a US product, that might be a 20,000 donor exposure, which sounds a huge number. But if you have one treatment from one company, one from another, and one from another company, that could be 60,000 donors. So the chances of becoming infected with something would have been much greater. But I think it did make a bit of a difference in terms of HIV, but I don't think it made much difference for hepatitis.
So first of all, it was a policy you inherited.
Oh yeah, I know, it wasn't my idea, no.
And the rationale was to reduce the risk of infection.
Reduce donor exposures and therefore, hopefully, reduce the risk of infection.
And how did that work in practice? How was a particular batch secured for a particular patient?
Well, I can't actually remember exactly how. I mean, I think once a person was on a particular batch, that would be on their record in the treatment room. So if they were not on home treatment and were coming up for ad hoc treatment, the same batch would be given if available. And if they were on home treatment and coming up to replenish their home stock, they would be given the same batch if at all possible.
We'll just look at a couple of documents about this. So could we have UBFT 40156, please? This is a later letter written in the context of HIV haemophilia litigation, but it's referring to an earlier letter from March 1984, and we don't have the earlier letter, Professor Franklin, which is why we're having to look at this as our best evidence of it. You refer to a letter that you'd sent to Dr. Allah, the regional director of the Transfusion Centre, in March 1984, outlining reasons for seeking continuity in factor VIII supply. And then you talk about supplies of material. NHS material had been very limited, and both myself and my colleague, presumably that would have been Dr. Hill, were of the opinion that it was better to make a gradual change to NHS products that could be sustained rather than a sudden switch in times of glut and then a sudden transfer back of all patients to commercial material. This was the sort of thing that had been happening at that time. And then you refer to there having been a meeting of haemophilia centre directors in which it was considered advisable that patients remain on the factor VIII product they've been regularly using. So that's the approach you were just describing, Professor Franklin. Therefore, it didn't appear unreasonable at that time to propose that patients who've been using ARMA for several years should continue to do so. There was never at any time sufficient NHS factor VIII available to treat all patients, and the decision of Dr. Hill and myself was that patients should receive a regular supply of one or other product and not a mixture of both. So, pausing there, the aim was if someone was receiving ARMA, they'd carry on receiving ARMA. If someone was on receiving NHS concentrate, they'd carry on receiving NHS concentrate as much as you could.
Not only that, they would stay on the same batch until that batch was exhausted, yes.
You've referred there to limited supplies of NHS material and then times of glut and having to transfer patients between different products. What, if anything, can you recall about that?
Well, I don't think we ever had a glut, actually, but we did. There were times when the supply of NHS product increased, and so I think there is some correspondence that you have between myself and the director of BPL, which made the NHS product. In light of that, I think we did transfer some people from commercial onto NHS in the hope that that would be sustained. In the end, it turned out not to be sustained, and I presume, although I don't have any records, I presume we had to move them back. I wasn't very happy about that at the time.
I think we might sense that from the tone of your letter to Dr. Lane, Professor Franklin.
Yes.
If we have a look at it, BPLL 40853_002, please, Henry. So this is your letter, 24th of May 1984, so a couple of months after the letter that we don't have, but we've seen described your letter to Dr. Allah. And you're saying here, as co-director of the Haemophilia Centre at this hospital, I've been most disturbed at the sudden fall in supplies of NHS material for our patients. It's only a month or so ago that I was requested to change some patients to NHS from commercial material because of a glut of the former at the regional transfusion centre. So it appears that there had been at least a temporary glut of NHS material. It appears that we will now be in the position of having to treat patients with commercial material who may never have been exposed to this in the past. This situation is particularly regrettable given the current interest among haemophiliacs in the acquired immune deficiency syndrome, and obviously we'll come on to that later, Professor Franklin. You go on to say our efforts to reassure patients have included maintaining them on a single product so as to limit the pool of donors to which they're exposed as much as possible. Not only will this sudden and unexpected shortfall in NHS material mean that we'll have to change this policy, but it will also make epidemiological studies of hepatitis and AIDS meaningless. What did you mean by the reference to epidemiological studies? Was that something you were involved with?
Not particularly as a study. I imagine that was just, as will come on, we came to know how many people were HTLV3 positive, and I suppose it would have been perhaps helpful to know whether any of those had been from people who'd only ever had NHS material.
And then if we just look at the next...
But there wasn't a trial or formal...
Not as far as your involvement is concerned. And then if we look at the next paragraph, could you perhaps let me know of the likely future supplies of NHS material so that I may plan the treatment strategy for my patients? And you go on to say that you find the sudden swings in supplies with no due notice to clinicians involved in the treatment of patients to be unacceptable. I think it's fair to say that Dr. Lane's response, which we have at BPLL 40853_001, suggests that this is an issue that you would need to take up with the regional transfusion centre rather than...
Yeah, it was fairly
BPL.
robust rebuttal, I suppose, but...
and we see that in his second paragraph. Regional transfusion centres and not BPL determine the issuing policy within individual reasons. And if we skip down to the fourth paragraph of the letter, he says, in relation to the sudden and unexpected shortfall, regional transfusion centres have monthly issue reports and 6 monthly updates at the time of pro rata. Your RTC must have been aware of their pro rata issue of Factor 8 as far back as December 1983 and known that this period would be affected by the yield and plasma supply. I mean, whatever the precise cause of the fluctuation, was that a situation that persisted as far as you can recall in those first 2 or 3 years that you were there? Was this a perennial problem?
To be quite honest, until I saw these, I'd sort of rather forgotten. I did know that I'd had some correspondence with Dr. Lane. This change in treatment obviously came at a really critical period, sort of 84. And I think that was why I was concerned about it. I'm not sure. I think after this, most of the major changes came about when the issue around requiring heat treatment came in, and that sort of really disrupted a lot of the regular supply issues. So I think after that, there was hardly any such thing as routine supplies for a couple of years.
Okay. It would seem that you received your supply of NHS factor concentrate from the regional transfusion centre.
Yeah, I think we got all the supplies from there, but as I'm sure you'll come on while you were speaking this morning about the contracts and so on, but I think it was all stored over there, yeah.
So the cryoprecipitate was from the regional transfusion centre?
Yeah, that would have been made locally.
The NHS factor concentrate was made by BPL at Elstree,
Yeah,
but supplied to the regional transfusion centre and then to you. And then the commercial products, we'll look at the contracting arrangements in a few minutes, but your recollection is they were delivered to the RTC and then hospitals would call them off as and when
I think we called them
required.
off as we needed, but it's a long time ago. I'm not 100% sure.
Well, if it assists you, Professor Franklin, the documentation suggests that for Queen Elizabeth, although not the Children's Hospital, that was probably the case. Just more generally in terms of the treatment policies, what use was there in this period, 1982, 1983, 1984, of cryoprecipitate?
Well, there was use. I remember doing it. I think your previous chart suggested that we were using it for von Willebrand's disease. I would have thought we were using it for mild cases. It really depended on the severity of the problem that was required, but we were definitely using it. But in the absence of any more sort of figures, I can't remember.
What about DDAVP?
Yeah, we certainly did use that. It was very useful, but it was really good for things like dentistry in less severe patients. As I'm sure you know, I mean, DDAVP works by releasing factor 8 from the body, from the blood vessels. So if you're a person with very severe haemophilia, 0 to 1%, you don't have factor 8 to be released from the blood vessels. But if your normal factor 8 level is between 5 and 10%, say, you actually have quite a bit. And the DDAVP would release that, and then you'd be able to give it perhaps for a couple of days to tide you over. But it was very short-lived. So it was something we used. I mean, I remember using it.
We saw reference this morning in the 70s to cryoprecipitate being used to provide cover for surgery. Was that something which was still happening when you joined QEH?
Yeah, I think it was, yeah.
And then in terms of NHS product as opposed to commercial, how were decisions taken as to which patients would receive NHS product, which would receive commercial? Can you recall?
Yeah, difficult. To be quite honest, I can't remember. I'm sure that if we had a young man transferring from the children's unit who'd only been on NHS, we would have done everything possible we could to try and keep them on that. But at times we had very little NHS, and so apart from that sort of more general comment, I don't remember specifics.
Presumably your product and batch policy would mean the converse as well. If you had a patient transferred from the children's hospital who'd been receiving commercial concentrators, we know many of the children did, you would have been likely to keep them on that.
Probably. It's unlikely it would have been the same batch perhaps, but yeah.
Was there any specific policy or approach or practice in relation to patients who were previously untreated patients?
Well, I don't remember ever treating, other than possibly some with DDAVP, who were very mild. I don't remember treating any totally new patients.
The arrangements for obtaining the commercial contract, the commercial product, we know that there was a regional contract in place, and it appears to have been with Armour at the time at which we're talking, when you arrived in 1982. As far as you can recall, was all your commercial product at QEH obtained pursuant to that contract, or did you ever make any separate arrangements yourself for the procurement of commercial concentrates?
In normal times, it was always off that contract. The period of time when I think maybe the BPL, but certainly the commercial unheated products were recalled, we went through a period of having very little. And although I have a vague memory of it, but you've provided papers to show that I actually made a personal plea to Armour for some extra supplies, which they did provide us with, which was, as commented by my colleagues, was outside the spirit of the agreement, but it's a difficult time.
And the criteria for awarding the regional contract for commercial product, before we look at any of the documents, your statement refers to Professor Hill suggesting that one might question suppliers of factor concentrates about their donor pools. Just look at your statement. I think it's paragraph 11.
Yes, I remember him doing that.
So what you say is, you talk about in the early years of your time working at QEH, you recall there being a committee of doctors in the region that determined which clotting factors were to be bought, and we'll look at that in the documents in a moment. And then, what is it you can recall about Professor Hill talking to you about donor pools and
well, he would ask about whether they were collecting blood from prisons, Skid Row I mean, this was after the 1975 Bad Blood, I can't remember the name of the programme now, but the World in Action programme. And there was, great concern about the quality of product. I know he had certain views about certain companies, but I think it was really a combination, I think, of trying to reassure himself and myself that we were hopefully getting the best product, and also perhaps to send a message back the other way that this was an important issue that companies should address.
You say he had certain views about certain companies. What can you recall about his views about particular companies?
Well, there is a letter in the papers from a surgeon in Stanford University to the then head of BPL, Dr. Maycock, being really quite damning about one company's product. And that company was one that Dr. Hill was never very keen on.
I think that's the letter from Dr. Garrett Allen to Dr. Maycock in 1975. Can you recall any other particular discussions you had with Professor Hill about specific companies?
No, none beyond that, no.
If we could just look at I think 3 meetings, one before you arrived, one whilst you were there but before you took over as director, and then 2 after you became director, just to get a sense of how decisions were taken. Could we please have Henry, SHIN 5030. So this is a meeting of the West Midlands Regional Health Authority's Working Party on the Treatment of Haemophiliacs. We looked at it this morning during the presentation, Professor Franklin. It's dated the 27th of June 1983. We can see Dr. Hill was there, and then representing QEH would have been Professor Stewart. So this is the time that you were a consultant at the hospital, but not yet director. If we go to the second page, we can see under the heading Regional Contract, it was agreed that Mr. Stanton should invite tenders, and then Mr. Shinton, Dr. Hill and Mr. Stanton would meet to adjudicate when the tenders had been received. So the process appears to have been, and we see it later involving you, that Mr. Stanton from the Regional Supplies Department was that someone from the Regional Health Authority?
I would have thought so, yes.
Would invite the tenders from a range of commercial companies, and then there would be involvement of 2 of the Haemophilia Centre directors here, Dr. Shinton, who was Coventry, Dr. Hill, the Children's Hospital, and Mr. Stanton adjudicating. And then we can see 3 criteria there set out, or points to be taken into consideration. The amount of effort involved in changing supplier. What, if anything, can you tell us about why that was regarded as important?
Not really. Seems a strange thing to say, really. I would have thought you'd want the best product. But there were differences which I've only been reminded about in the last week by reading a lot of this correspondence and meeting papers, that the different companies prepared different packs. Some of these were perceived to be easier to use by patients at home than others. I can't see what other amount of effort was relevant, really.
And then the second point, where firms have their donor facilities in the United States, so that goes back to the issue that you were discussing a few moments ago.
Well, I did think they all did. Maybe Immuno didn't. I know possibly Bayer didn't, but Bayer, I think, never made a lot of product, and it was very expensive. But as far as I knew, they were all American products.
This appears to be looking at where in the United States the donor
Oh,
facilities
sorry,
were.
I see. I'm sorry. Where? Right,
Whether.
different meaning of where. I beg your pardon. Yes, where in the United States they had their collection facilities. Yeah, which would be away from major conurbations and places where.
You may not remember this, but was there any appreciation that a number of the commercial firms may have got their plasma supplies not from their own donor facilities, but from plasma brokers?
I certainly didn't have any awareness of that at the time. I think I became aware when I was more involved in plasma fractionation in Scotland, but not at that time. No, I think it was an assumption they were going. We knew they were paid donors, but I think the assumption was that they were going out and collecting their own plasma.
Yes.
Yeah.
And then we see the third point that's identified to be taken into consideration is any public pressure for a change of products, e.g. to heat-treated factor VIII, should be resisted until another product had been proved to be more satisfactory. Do you know what the reference to public pressure refers to?
No. We
can see that, as at June 1983, there's a reference to heat-treated factor 8. We'll come on to how and when QEH moved to using heat-treated products, which was either at the very end of 1984 or the beginning of 1985, as far as we can tell. Do you recall any consideration being given in the course of 83 or 84 to starting to use heat-treated products earlier?
No, I think my only awareness of a heat-treated product was the Bayer product, which was, as I say, very expensive and beyond our budget. No.
If we go to the next page, please, Henry. Sorry, actually, no, we'll go back to the previous page. My apologies, Henry. If we just look at the bottom part of the page, Professor Franklin, under the heading Supplies of Cryoprecipitated and Freeze-Dried Factor 8, we can see there's a discussion about what's described as receipts and purchases, so presumably who's using what in terms of Factor 8. There's a reference to a letter from Dr. Shinton about the risk of AIDS, and we'll come back on to the question of AIDS. But then there's a reference to asking the working party to advise on the purchase of heat-dried Factor 8. So that appears to be something that at least Dr. Aller was raising in June of 1983. Was that something that you recall becoming involved with advising?
No, as you point out, I wasn't at this meeting. It's quite prescient of him. But I don't remember any particular fallout or progression of that idea.
Okay. And then the next page, please, Henry. We could go to the heading Funding of Commercial Factor 8. I don't know whether you can assist Professor Franklin in understanding what's being discussed here. In the second paragraph, it's referred to, there's an issue about deducting from districts with haemophilia centres in order to top slice and the possibility of applying for RCCD funds. Do you know what any of that refers to?
RCCD is the revenue consequences of, I think it might mean revenue consequences of some sort of development, capital development. The West Midlands Regional Health Authority had these sort of arcane phrases. I don't know whether they were common across the NHS, but so we were often applying for money to support the haemophilia patients from something called the Regional Consequences of Services Capital Developments, RCDRS. So they had basically, these are systems which the region divvied up the money that they presumably had from the central government. And probably in 1984 I would have been able to work my way around this, but I'm afraid I can't anymore.
Don't worry. We'll move on then to the first of these meetings that you did attend. SHIN 5029, please, Henry. So we can see this is a meeting on the 5th of December 1983. You'd taken over as director by this time, although Professor Stewart was there. You were there, Dr. Hill was there, and a number of others. If we look down the page towards the second half of the page, we can see under the heading Regional Contract that Dr. Aller informed the committee that the lowest tender was forwarded by the present supplier, Armour Pharmaceutical Corporation, and no change was envisaged. So it doesn't appear that there's any discussion, at least here, of those points that we saw referred to in the previous document. It just seems to be here the contract's been awarded on the basis of price. Do you have any recollection or understanding?
I don't, but I would perhaps suggest that that might still have been going on in the background. Obviously, the tendering process was developed to separate us as the users from the spending of the money. I would have still thought that those requirements, even if they were slightly strange, the three requirements would have still been informing the decision as to which companies to ask to tender. But obviously that's a very brief minute, so it's not explicit, is it?
No. If we go to the next page, just two further points to pick up. We can see that under any other business, Professor Stewart informing the committee that this would be his last attendance, and in future you'd attend as sole representative. So we just go down the page. So we see that under any other business.
Yeah.
And then just going up from that, the paragraph headed AIDS. So this is now December 1983. There's reference to there being a handout at donor sessions at the Blood Transfusion Centre. And then it says this: it was agreed that if any case of AIDS was suspected, then the Regional Public Relations Office should be informed in case their help was required. Are you able to cast any light on that? Because at first blush, it seems a bit odd to see the Public Relations Office being involved.
Well, tragically, we did ultimately have men who developed AIDS, and I don't ever remember talking to the Regional Public Relations Office about it.
And then if we go on to the next meeting, which is SHIN 5028. So we're now in May of 1984. You weren't, in fact, at that meeting. You sent your apologies. But if we go over the page, we can see in the top section of the minutes, it says, from the annual statistics and supply of BPL expected, there could be a shortfall of 3.5 million units to be made up from commercial sources. The working party agreed that Mr. Stanton should in due course invite tenders and subsequently meet with Drs. Franklin and R.M. Ibbotson to adjudicate. So just pausing there. On this occasion, it appears that the assessment of tenders is going to be by Mr. Stanton. Dr. Ibbotson, where was Dr. Ibbotson from?
Stoke-on-Trent. I know him well. Yeah.
And Dr. Franklin, so yourself.
Yeah.
And then it was agreed that the following points should be taken into consideration, and we see the same 3 points there articulated. So this is for the next round of the contract. Can you recall anything about that subsequent adjudication process?
No, I don't remember that at all.
So you don't know whether it would have been an informal or formal process, or records kept of it?
Well, ideally they would have been kept, but I don't recollect any such meeting.
Do you know what, if any, steps were taken to get the information that would help you consider point 2, the point about donor facilities? What questions were asked or inquiries were undertaken?
Well, the only inquiries I remember were those that I think I also did ask, in having been trained by Dr. Hill as to what questions to ask. Probably asked myself, but I don't know whether the supplies department asked those questions in a formal way and required anything in writing. I don't know.
Okay, I think we can see some evidence when we get into about 1986 of perhaps a more structured approach, but we don't have anything very clear from this stage. Apart from the reference to donor facilities, we can see that there is no express reference to any other aspect of safety or risk. Can you recall whether that factored into the decision-making process at all?
Well, knowing what I know now, I suspect that it was accepted that all these products had non-A, non-B hepatitis in them. And that the issue of where the plasma came from was our only lever, if you like, of trying to manage that risk in any way.
In your witness statement, paragraph, Professor Franklin. Yes, so two passages I wanted to ask you about. Paragraph 13, do you have a copy of your statement?
Yeah, I do.
Actually, we can put it up on screen. Henry, it's WITN 4032001, please. And if we go to page 14. So paragraph 13, this is now talking about particular products for treating patients. You say this: the particular products used for treating patients at the centre depended on availability, which changed over time, and we've touched on that. Previous treatment history, is that a reference to they've already been on this product?
Yeah, whether they were always on NHS or commercial or vice versa.
And then you say, and also the specific reason for treatment being needed. What does that refer to?
Well, I would think if you had someone who may have been a less severe haemophiliac, who you might try to use DDAVP for tooth extraction or possibly cryo for, I don't know, a hernia operation. And if they had bowel cancer and needed a major resection, you might feel you had to use concentrate.
And then if we go, please, to page 22, paragraph 18. You say in the first sentence, decisions were taken on the basis of an assessment of risk and availability. We've covered availability. What did you mean by an assessment of risk?
Sorry, can you just run back up to the precise question?
Yes, of course.
Right, there we are. Well, I think probably I've kind of explained that. If the risk was relatively low, tooth extraction, something like that, then you definitely try to use DDAVP if you could, and then so on down to a major cancer operation. I think I mentioned somewhere else in my statement, one patient had a large bladder tumour that needed quite a big operation. I mean, that really had to be done under concentrate cover. And I think they're the risks. That's the risk strategy, isn't it, really?
What role did patients have in decisions about what treatment to have at this time, 83, 84, 85?
Well, any patient is at liberty to refuse any treatment at any time. I realise that might sound a bit glib, but it's true. Beyond that, probably not a lot. I mean, we would have recommended what we thought was appropriate for the particular procedure they had.
Can you recall whether patients were ever offered any kind of choice of treatment? So you correctly observed there's obviously an entitlement in principle to refuse.
Yeah.
Were they ever given a choice between, for example, NHS concentrate and commercial concentrate?
To be honest, I'm not sure I ever had that choice to offer them. The supply of the NHS product was insufficient. So I think possibly not, really.
What about a choice between concentrates and cryoprecipitate? Was that a choice that was offered?
I don't remember offering that as a choice, no.
You talked about assessment of risk, and much might depend upon the circumstances of the patient and the risk of, for example, the bleed. Could we just look at your evidence, your written evidence to the Archer inquiry? There's just one point I wanted to pick up with you. Henry, it's ARCH 40443. could we go please to page... I'm sorry, we've only got this annotated version of
Yeah,
of
I
your
couldn't
statement.
find a clean version for you.
Are these your annotations?
I don't think so. It's
No.
not my writing, no.
No, we didn't think so either. If you could go to page 5, please. It's the top paragraph. I'm going to come back at a later stage of your evidence and ask you about the precautionary principle, Professor Franklin. But you say this, it's about 6 lines down. The regular use of factor 8 as a home therapy was a quality of life rather than a life-saving approach. Most home therapy was for incipient joint or soft tissue bleeds. These are not trivial, they are very unpleasant, but in the main they're not life-threatening. Do you see that? Because some of the evidence the inquiry's heard has posed this choice between life-saving treatment to prevent, say, a cerebral hemorrhage on the one hand and the risks of treatment with concentrates. But as I understand the evidence you were giving there, you were making the observation that most treatment for haemophiliacs is of the life-enhancing rather than life-saving nature.
Well, I did think that, and I'm not sure I've changed my view. I mean, I'd have to preface that by saying I was not one of the long-standing haemophilia doctors who'd seen haemophilia care before decent treatment was available. And the long-term effect of even these bleeds in some of the survivors that we did have was pretty devastating in terms of arthritis, employment prospects, personal relations, education. But I was always slightly suspicious about the idea that if we didn't carry on using concentrate, and I did carry on using concentrate, that if that was stopped, then suddenly many people with haemophilia would have died. I mean, if you develop cerebral hemorrhage when you're at home, you need an ambulance. You don't need someone to put to get cryo out of the freezer. I think that was my feeling. So I was always a bit sceptical about this, but I have to confess, I was at the meeting when Professor Bloom said we should carry on with concentrate, and that's what I did.
Yeah,
So.
and we'll come on to that. So I know the time, I think, I'm about to move on to a topic which will require looking at quite a lot of documents. So would this be a convenient point to take a half-hour break?
Yes, well, let's take a break till 3:30. 3:30, if you